From St. Louis Public Radio. This is the Politically Speaking Hour on St. Louis on the Air. I'm Jason Rosenbaum. Later in the show, we'll look back at how the late Congressman Bill Clay forged a monumental legacy through his advocacy for civil rights and black political power throughout the St. Louis region. But first, Todd Richardson would never be accused of having a tranquil time during his nearly 15-year tenure in Missouri state government. Richardson became House Speaker abruptly in 2015 after a scandal brought down his predecessor. And his last House session in 2018 coincided with the demise of Eric Greitens' governorship, placing the Poplar Bluff Republican in the spotlight amid high-profile impeachment deliberations. Richardson's post-elected life hasn't gotten any less eventful. He's the director of Missouri's Medicaid program, a massive enterprise that helps low-income, disabled, and elderly Missourians pay for critical healthcare services. Since taking on that role in 2018, Richardson dealt with upgrading antiquated technology, a once-in-a-generation pandemic, and the advent of a historic Medicaid expansion to the working poor. And now, thanks to Congress and President Donald Trump, Richardson could oversee new work requirements and the potential depreciation of medical provider taxes that Missouri used for decades to pay for Medicaid. Last week, I went to Jefferson City to talk with Richardson about how Missouri's Medicaid program works and some of the longer-term challenges and opportunities for the state's healthcare system. I started off by asking a relatively straightforward question. What is Missouri's Medicaid program, which is known here as MoHealthNet, and how many Missourians depend on it for health care?
Missouri HealthNet is Missouri's Medicaid program. Been a lot of discussion about Medicaid in the news of late, but Missouri Medicaid is a program that's been around since 1965, and in general provides coverage for those Missourians who are most in need, is the way we would describe it. So we have about 1.3 million Missourians on the program today. That's comprised in our large eligibility groups of our age blind and disabled population, kids, a ton of kids on the program. And then also through the voter-approved Medicaid expansion, we now have about 300,000 adults on the program.
So you just described Medicaid in shorthand, because when I describe it, I say it's a healthcare program for low-income, disabled, and elderly people. And I want to dig a little bit deeper on that descriptor. Why would older adults, for instance, need Medicaid when they have access to Medicare?
Yeah, we have a tremendous number of individuals who are what we would call dual eligible. So they're eligible for Medicare and Medicaid as a result of their income. Medicaid has become one of the largest, it is the largest provider of long-term care. So a lot of our nursing home care in the United States, and this is true in Missouri, is paid for through Medicaid.
Now, can you describe how Medicaid is available for people who are disabled?
Yeah, it's available in Missouri based on a disability determination. So our colleagues at the Family Support Division here at Social Services employ a medical review team. So if somebody applies by virtue of that disability, that medical review team looks at the individual's circumstances and makes a determination of whether they're disabled. Very similar, I believe, identical criteria that Social Security uses for the purpose of their disability determination.
One of the things I've read throughout the years is that there's often tension between disabled Missourians who need access to Medicaid but can't earn as much money as they could potentially make since they'd lose access to the program. How does somebody navigate that, especially if they want to earn enough money to live independently?
Yeah, I think it's an area of the program that we need to look at, Jason. It's we certainly don't want, and I think this is true for a larger suite of our social services programs, we certainly don't want there to be a disincentive or something that prevents somebody who wants to earn more. I was talking with members of the General Assembly, a member of the General Assembly about this yesterday. So I do think it's an area that we need to look at and where our income thresholds are and how we allow a little flexibility for that person who is on disability but has the ability to earn an income to keep the services that they very much need from Medicaid.
Correct me if I'm wrong, but hasn't there been some sort of legislation that aims to like do a step down as opposed to a cliff? Has that just not been fully implemented yet?
We have a method in Medicaid today that we call spend down, which is a somewhat complicated process, but it allows somebody to spend down their income on qualifying medical expenses and retain access to care. So we do have some of that ability today, but I know there are advocates and individuals on the program who would like to see more done there, and I think we would be open to those conversations.
I want to talk about kids, though, because I would think that like one of the larger groups is through the Children's Health Insurance Program. Can you tell me how that dovetails with Medicaid in general and maybe how it's different from some of those other categories?
It operates in our state very similar. It's a category of eligibility that individuals are entitled to kind of the same suite of benefits that the rest of the program is entitled to. We have kids on the program not just through CHIP, but also through what we would call straight or regular Medicaid. But it's a full suite of insurance benefits, just like you or I would think about our health insurance plans.
The eligibility is much higher than an adult. Can you talk about that?
Yeah, we cover children up to 300% of the federal poverty level, which is a fairly high level. Not every state's at that level, but what comes with that is a requirement that there's a premium once you hit certain eligibility categories. So or certain income thresholds. So it allows us to open up Medicaid coverage for those kids that need it, but also to do so in a fair way by assessing that premium.
And does the premium go up depending on where you are in the income scale? So
It
let's
does.
say you're at 299% of the federal poverty level, your premium will be higher than if you're at 167,
Correct.
basically. We've talked about who's eligible. I want to talk about like what would happen and what you can get if you're actually on Medicaid. So let's just say I qualify for Medicaid under any of these categories and I want to get health care services. How would Medicaid work in order for me to get access to that?
Yeah, Medicaid operates very similar and almost identically from a patient perspective to our private insurance plans. So you go to the doctor. In the case of our managed care participants, they're going to have an insurance card from one of our three managed care plans, and they're going to go to a doctor, and that insurance is going to pay for the services. So we cover all of the things that you would think of as traditional healthcare services. We cover hospital care, doctor's office visits, pharmacy programs, and then including some long-term care benefits as well that aren't always covered in traditional health insurance plans.
A person doesn't just get a lump sum of money
Right.
and then they spend it on health care. Can you explain that process, which may seem obvious, but I
Right.
think is important to point out here?
Yeah, outside of a very, very small percentage of our budget, less than 2%, which goes to administration, the entirety of the money that gets appropriated to MoHealthNet goes to pay providers. And so when a doctor in Missouri sees a Missouri Medicaid participant, they're going to submit a bill for that, and we're going to pay that bill. So all those dollars associated with the program are going not to the participants, but going to the medical providers, whether that be a doctor, a hospital, a pharmacy, for the services that they're providing.
Now let's go to adult enrollees for Medicaid. You have been the director of this program when, as you mentioned, Missouri expanded Medicaid under the auspices of the Affordable Care Act. That means that people who are making up to 138% of the federal poverty level can now qualify for Medicaid. It's been about, 4 years since it's happened? How has that gone so far?
I think the implementation and the start of the program has gone incredibly smooth from the state's perspective. It is not an easy task to take a program like this and open it up to now 300,000 additional participants. It was almost a 30% expansion of the enrollment in our program, but I think it's gone very well. Obviously, that happened at the same time the state was operating under the federal public health emergency and continuous eligibility requirements as a result of COVID. So we have had a lot of flux in terms of, and a lot of change in terms of where our enrollment overall in the program is. But I think overall, Medicaid expansion has gone fairly well in Missouri, certainly from a participant and a provider perspective. I think there are the longer term, strategic or sort of macro challenges with what it means for the state's budget and how we ensure that benefit and the program overall are sustainable over time. And that's been a lot of what we've been working on in terms of the budgetary picture relating to expansion.
And you kind of read my mind, because that was my next question. I've covered the question about whether to expand Medicaid for almost 2 decades now. And the biggest argument, especially from the Republican side against that, was the long-term cost. But Missouri ended up getting, I believe, $1 or $2 billion from the federal government from the American Rescue Plan. Has that helped defray whatever the state would have had to pay for its share of Medicaid expansion, at least in the short term?
Yes, the short answer to that is it has, and it's pushed off the need to use general revenue to fund the expansion portion. But once those funds are exhausted, it's going to be a cost, and so we're obviously going to work with our partners in the General Assembly to make sure that it doesn't have the kind of negative impact on the budget that some people fear.
Do you know how much longer that's going to last as a way of supplanting general revenue before it runs out?
I think you can expect that in fiscal year 27, we just started fiscal year 26, but in fiscal year 27, we'll start to have that need.
Is there any, I mean, this is a difficult question because we just don't know what the need is going to be in a year, but do you have any estimates about how much general revenue the state is going to have to put up for the Medicaid expansion program at this point?
I don't have it for fiscal year 27. In broad terms, and in very general terms, we're spending about $3.5 billion on the expansion program. Missouri's share of that is 10%, so $350 million in ballpark numbers.
Yeah, and I'm sure that you were watching very carefully the One Big Beautiful Bill's deliberation, where they were thinking of dropping that by 2031. Whether you were still Medicaid director by then, right, who knows? But given that that is in the Constitution and the state can't just turn away enrollees, can you talk about how fiscally damaging that could have been without major changes to the Constitution?
Yeah, changes in the match rate for the Medicaid expansion population would have been very difficult for Missouri to deal with. As you mentioned, our Medicaid expansion benefits in the Constitution specifies what level of benefits are included with the expansion population. So it would have been very difficult for the state to weather a change that would have been a significant increase or decrease in the level of federal support for the program.
When I talk about kind of technology and the way Missouri's Medicaid system operates from a functional level, I'm sure we could get really into the weeds with computer systems and computer programs that I have no way of really asking an intelligent question about. But let's just say when you started here in 2018, how outdated would you say the technology was in terms of managing the program compared to now?
I've heard others describe it as the best technology money could buy in 1978.
1978?
We do have some systems that are that old, but there has been I think the systems were they did what they were designed to do very well, and some of them continue to do what they were designed to do very well, but they certainly presented limitations for our staff and for our ability to manage the program. There has been a dramatic improvement in our systems. Still more work to do there, but our ability to access and use Medicaid data today, and particularly to use it to drive informed, data-driven policy decisions, is miles better than it would have been back in 2018.
We need to take a short break, but when we come back, we'll continue my conversation with Todd Richardson, the director of MoHealthNet. This is the Politically Speaking Hour on St. Louis on the Air. Welcome back to the Politically Speaking Hour on St. Louis on the Air. I'm Jason Rosenbaum. We're now going to continue my conversation with Todd Richardson, the director of Missouri's Medicaid program. I conducted this conversation in Jefferson City last week, and I talked with him about how the One Big Beautiful Bill could make major changes to the healthcare program for the working poor, elderly, and disabled. From a technological standpoint, how prepared is Missouri to make sure that Medicaid enrollees can comply with whatever work requirements end up being put in place?
Yeah, work requirements is obviously something that's going to be brand new to the program. I think we're excited about the opportunity to be able to implement work requirements. It's been an idea that the state has had around for a while. So the ability to do it is I think a welcome opportunity for us. I mentioned earlier that we focus a lot on the sustainability of the program, and I think ensuring that that our Medicaid expansion population is meeting those work requirements is obviously going to be an important part of that sustainability picture. But we also want to make sure that that's done in the least difficult way for the participant. The ability to do the verifications that someone would need to have electronically now has improved dramatically from where it would be 10 years ago. So, I know, I think you're aware the state has a partnership now with a company called Steady IQ, which helps do income verification. We also have other partners like at Equifax that provide data in that lane as well. So I think what will be important is for the state to make sure that we're making good use of those tools, make sure, number one, we're getting the verifications done correctly and accurately, but also to do so in the way that's the most efficient for both the state and for the participants.
Yeah, there's been obviously a lot of discussion about the work requirements and how they could potentially be crafted in such an onerous way that even people who qualify for Medicaid end up losing their coverage. My counterpoint to that is if you set up a system where it's pretty easy to access a portal or a website where you just upload documents and it takes you 10 minutes twice a year, then I could see people being able to comply with that relatively easily, especially if there is an education campaign to let people know what the requirements are. That's more of an observation than a question, but is that something that your department is going to strive to do whenever these work requirements go into effect?
Absolutely. Our goal is to make sure that people who are eligible and entitled to be on the program have the easiest path to get access to those benefits, while at the same time ensuring that those who are not eligible for the program are not on the program. So with the tools that we have today, I think what participants will see is a process that really is smooth, because even beyond a portal where people can upload documents, there's a lot of this verification that can be done without the participant having to do anything at all. And so I think for a lot of those individuals, our hope is that we can do that verification in such a way that it's no touch from the state or the participant.
Can you kind of elaborate on that? I know that, again, the work requirements are still kind of in flux, but how would somebody be able to comply with them without doing anything?
Well, if they're working, and we can verify that they're working through income data, then that's a verification right there. Now, there are other exceptions to the work requirements that probably will require a participant to send some documentation or to involve a human, but I think there's a lot of that income verification that can be done electronically.
Yeah, and I think that's been where a lot of the criticism of this has come in from, I guess, the left end of the political spectrum, especially if you're on the Medicaid expansion side of Medicaid. You are working. I mean, otherwise, I don't know how you're getting $15,000 a year unless it's falling out of the sky. But this is seen as just sort of a paperwork trap that may kick eligible people off of Medicaid. You've probably heard these arguments before. As an administrator, what is the argument for work requirements that would make this Medicaid system stronger and better in your view?
I think it's about it being sustainable for the long term. And I think that's at the core of why work requirements were included in the reconciliation package. But we want the program to be available for those who need it. And work requirements is a way to ensure that the population on the program is sustainable for the long term.
Do you know what the timeline is that you have to have the work requirements in place?
We've got a number of different timelines because work requirements isn't the only eligibility requirement that's in the one big beautiful bill. I believe the work requirements provision kicks in at the start of 2027.
Now, I think that the provision of the one big beautiful bill that had, I think, the most controversy even among Republicans, because let me just kind of peel back the political curtain here. I would say that the work requirements were pretty much had unanimous Republican support in Congress. But the medical provider tax restrictions were really controversial among Republicans. It's the reason why Tom Tillis didn't vote for it.
Yep.
Josh Hawley had raised alarm about it, and he's trying to actually repeal it. Explain what Missouri's medical provider tax is, who it covers, and how this bill would affect the medical provider tax down the road.
Provider tax is a structure that's been in place in Missouri since the early 90s, mid-90s, and it's a way that we help finance our Medicaid program. So in short, it's a tax that's levied on we levy it on hospitals, nursing homes, ambulance districts, and pharmacies to different degrees and different levels, but most of the focus on the federal bill was about the hospital portion of that tax. The state levies a tax on hospitals based on a percentage of their total revenue. We take those tax dollars into the state, and we use those to finance a portion of our Medicaid program. So that's how the program operates. It's been in place for a long time.
Do you know what the tax is right now? The Missouri Hospital Association said it was 4.2%. I read another article that said it was 5% on hospitals. I want to make sure I know what the percent is right now.
But both answers are correct. Our hospital tax rate varies based on the way the General Assembly appropriates our budget and based on what the need in the program is. For fiscal year 25, our tax rate was 4.2%, and for fiscal year 26, which we just started, it will be 5%.
Okay, so yeah.
So both answers are right. We are currently less reliant on the provider tax than we have been in the last 20 years, which has been a lot of work. It's been a focus of the department. It's been a focus of the General Assembly. So while we're not unconcerned about the potential for that cap to go down, because what's in the bill is that cap would go down from a current level of 6% today to 3.5%. While we're not unconcerned about that change, we're in a much better position to deal with that than we would have been if we still had our tax rate pegged out at the 6% cap, which is where we were just a few years ago.
Is the 5% cap now frozen? It could go up to 6% right before it goes down.
No, it's now frozen at where it is in time. So the tax the amount that the tax generates could go up, but the 5% is now where we are until that cap goes down.
From reading the bill, I think in 2028, that's when it drops to 5.5%, which wouldn't affect Missouri because we're at 5. It would start affecting Missouri probably around 2030,
2030, 2031, somewhere in that neighborhood.
Yeah.
It's also a little bit speculative, right? Because as I mentioned, it's the tax is based on a percentage. And so when the demand floats up and down, whether that has an impact in 2030 is a little hard to estimate as we're sitting here in 2026.
As kind of a compromise here, there was this $50 billion rural hospital fund. Senator Hawley says Missouri is going to get about $1 billion worth of that. Do you have any sense of how the state can use that money, or hospitals are this just going to go directly to hospitals, or would it go through the Medicaid program?
The state must submit a plan to CMS by December 31st of this year for how it would allocate those dollars. So we're actively working along with others in state government on what that plan should look like, and obviously that's something that ultimately will be Governor Kehoe's decision to make. But we're certainly going to be involved in framing up some of the options for how those dollars would be allocated. We're very excited about that. that fund and the ability to be able to provide some direct support for rural hospitals. It's something that's been a focus of MoHealthNet for the last 6 years, and this gives us some additional resources to focus on it.
Again, this is speculative because we don't know if the medical provider tax restrictions will ever go into effect. Like if there's a Democratic president and a Democratic Congress, like it could be repealed. Like That's kind of why talking about this with certainty is kind of a fool's errand. But let's just say they do go fully into effect. There's a lot of fear that that could really hurt rural hospitals down the line because the state will have to come up with the money to fill the hole in the Medicaid program, and it may be shifting from education or maybe paying providers less. Does that concern you about the impact of this if it goes into effect?
I think there's a lot of time for us to figure out how to manage that if it goes into effect. I think I certainly understand where the concern comes from, and I think there are very good reasons to be concerned about what the future of healthcare looks like in the rural parts of our state, which is why I think you see so many policymakers trying to focus on it. I think it's why you see MoHealthNet focused on it, and I think it's why you see our federal partners focused on it. We are sliding down a path, and this is not a Missouri-specific statement. We are sliding down a path where we have two types of health systems, big of hospital-based systems, large ones and extinct ones. And I think that's a problem that policymakers and administrators of Medicaid programs are going to have to wrestle with, which is how do we ensure that rural Missourians continue to have access to health care? Maybe it doesn't look exactly like it did in the 1970s, but those communities still need health care and they still need access to the care. And that's a growing problem that's not necessarily driven entirely by changes in Medicaid policy or federal spending. It's more a systemic challenge that I think healthcare is facing, but it's something that we've got to figure out a solution to.
Yeah, and I want to touch on that for a minute because Poplar Bluff still has a hospital, correct?
Yeah.
Okay, so one of my friends used to live in Donovan, Missouri, which used to have a hospital and no longer does. And what she told me is after access to healthcare there shut down, people moved to Poplar Bluff, and that kind of hollowed out a community like Donovan, which has a long and storied history. And this has probably been replicated in many other smaller rural cities across the state. How you solve that problem, though, is I don't know how you solve that problem, because if the demand isn't there for hospitals to be financially viable, either they're going to have to be heavily subsidized by the government, or you're going to just have smaller healthcare systems there that are not hospitals. Again, more of an observation than a question, but I think that this is more than just about access to healthcare. This is about the economic vitality of rural Missouri.
Yeah, I mean, I've actually referenced the Donovan example quite often. I also reference one from Kennett, which is but both in my neck of the woods, so to speak. Donovan used to have a 50-bed full-service hospital, and the reality is the market's not going to support a 50-bed full-service hospital in a community like Donovan. The challenge is that community still needs access to healthcare, and the observation that you make is one we have seen in other places, which is if the hospital closes, generally it means a degradation of the rest of the healthcare infrastructure that was around it. So I think the challenge going forward is how do we find a model that's not so much focused on trying to maintain what we had, but how do we develop a model that's focused on trying to ensure that the healthcare that the community needs is present there. And that probably means something that looks different than that 50-bed full-service hospital in a community the size of Donovan.
Could be telemedicine. But you need access to broadband for that to occur.
Yeah, I mean, telemedicine certainly plays a role in that. But I think you've seen the advent of what's now called the rural emergency hospital designation, which provides an opportunity for a very small emergency department kind of focused hospital where you could build urgent care around it. Our FQHCs, and Doniphan's an example of this, continue to fill a really important role in communities like that, providing the backbone of some healthcare infrastructure there now. So I don't know that anybody's got the answer completely figured out, but I do think there are some things that we're trying to do at Medicaid to improve the sustainability of healthcare in those areas.
That was Todd Richardson, the director of Missouri's Medicaid program. You can listen to more of my conversation with Richardson by going to STLPR.org. We need to take a quick break, but when we return, we'll discuss the monumental legacy of former Missouri Congressman Bill Clay. This is the Politically Speaking Hour on St. Louis on the Air. Former Missouri Congressman Bill Clay received an outpouring of praise after he died last week. And who could blame anyone? Clay left an absolutely titanic legacy during his 94 years on Earth. He actively sought to dismantle racial discrimination as both an activist and a member of the St. Louis Board of Aldermen. He became the first black person to ever represent Missouri in Congress, and he helped pass landmark labor legislation, most notably the federal family leave law in the early 1990s. What's remarkable here is that Clay managed to accomplish all of those things while facing withering criticism during his time in office. His adversaries commonly derided him as a radical and divisive figure, but Clay didn't see those slings and arrows as particularly unusual. During a 1992 speech in Washington, D.C., promoting his book, Just Permanent Interests, Clay noted how movies and racist politicians often caricatured post-Civil War African-American elected officials as lazy, stupid, corrupt, and alien to the people they represented.
And contrary to the omissions and the distortions about them, these were some fabulous and fascinating people. The birth of a nation was a shame to this nation when they depicted the black elected officials as being uneducated, as being uncouth, as sitting in legislative chambers and eating chicken and throwing the bones on the floor. These were downright damn lies. The 22 members who served in the Congress during the Reconstruction era were not buffoons. They were honorable. They were the most educated, the most politically experienced, probably of any group of people who served in that Congress.
Perhaps one of Clay's lesser talked about accomplishments was how he created an environment that allowed other black officials to obtain real, tangible power in St. Louis. He parlayed that into the national arena when he helped create the Congressional Black Caucus, a group, as he explained in the 1992 speech, played a critical role in preserving some of President Lyndon Johnson's policy agenda.
You see, if it had not been for the leadership of the Congressional Black Caucus in coalition with some other liberal elements in the Congress, the Great Society programs would have been destroyed in the Nixon administration. Nixon rode into town thinking he had a mandate. Only got elected by less than 1% of the vote. But he thought he had a mandate to destroy the Great Society programs. And he advocated it. But we beat him at every turn.
Clay was masterful at banding together unusual coalitions. In his early years, he developed a bond with organized labor, particularly the pipe fitters union. And he strongly defended the redistricting alliances between Republicans and Black Democrats, who both wanted to keep the 1st Congressional District majority African American. But in Just Permanent Interests, Clay noted that he was able to succeed because he didn't grasp on to elaborate fantasies about what politics could be. Instead, he wrote that politics was a deadly serious enterprise with rules structured to ensure that only the strongest survive. He added that neophytes, weaklings, and the unprepared entering this domain are quickly entangled in a maze of confusion, baffled by contradictions, and bewildered by numerous confirmations. Black politicians who obtained power after Clay, such as former St. Louis Alderman Mike Jones, also developed a clear-eyed view of politics.
Fundamentally, politics is a real simple business. You can have what you can take. You can keep what you can hold. Okay? That it's yours for as long as you can keep it. Because you want it don't mean you own it. Okay? And just like you came for somebody will always be coming for you.
Clay often needed to stay on guard, not just against white political adversaries or the media, but also other black political officials. One of the consequences of developing a vibrant political environment for African Americans is that Clay sometimes faced challenges from within, and those were not friendly sparring matches. One opponent erroneously accused Clay of hiring a hitman to kill his political rivals. And his son, former Congressman Lacy Clay, pointed out that in 1982, his opponent accused him of being out of touch.
His opponent put out a commercial that was kind of effective and said that Bill Clay travels between Washington and St. Louis on first class. TWA was the airline St. Louis was the hub for Trans World Airline. And my dad held a press conference when he got off the plane one week at Lambert and said, yes, the voters in my district would expect nothing less than a first-class congressman. And that was his response, and that issue went away. He was witty, he was funny at times, but he could be very serious and focused, too.
It's worth noting that Bill Clay didn't magically remove all the obstacles that trip up St. Louis's African American officials. For the most part, black politicians often have had a lot of trouble raising money, putting them at a distinct disadvantage when they contemplate running for some post in St. Louis or St. Louis County. And earlier this year, St. Louis Alderwoman Alicia Saunier explained in painstaking detail a familiar type of criticism she regularly faced since she became an elected official.
We do not get the grace periods that other leaders get, and especially there's high criticism levels. I've gotten emails from people saying, you speak in Ebonics, and this is not the ghetto. I've had comments from people on my hair. It's too long. Why is it that color? People comment on my nails and how long my skirt is. Someone who is a counterpart that might be a white male could come in a Hawaiian shirt and flip-flops, and nobody's going to really comment or say anything. And so I definitely think that those standards are there. And while I hold that those standards are there, I think that racism and sexism, those things existed before I was here. They're going to exist while I'm here, and I'm not going to let those be the reasons that I'm not successful, and I'm also not going to let that be the thing that other black leaders have in their head and they don't try to go and lead their communities, and that persuades them from thinking that they have an opportunity to lead and to be supported.
I would hesitate to extrapolate too much from Clay's experience to all of modern-day politics, especially since much of his focus was on the betterment of black people as opposed to the betterment of the Democratic Party. But Clay's ability to plainly speak out against obvious injustices, even if it made him enemies, did seem to be a winning electoral strategy. He never lost an election when he was running for Congress or the Board of Aldermen. And perhaps keeping firm to guiding principles like he mentioned during his 1992 speech in Washington, D.C., could provide more credibility to potential voters.
That we should never lose our basic interests. Because one of our problems is that we get more concerned about other people's interests that we lose sight of our own. Now, we can have a coalition with environmentalists, with consumers, and with organized labor. But running through all of that is a strand that says we're black And that's our primary interest. And until we live in a society that's colorblind, it will remain our primary interest. So the title of this book comes from the motto of the Congressional Black Caucus, which says that black people have no permanent friends, no permanent enemies, just permanent interests.
There may never be another Missouri politician like Bill Clay ever again, but that doesn't mean the people who walked on the trail he blazed can't make a mark of their own to reach the elusive goal of liberty for all of St. Louis and all of America.
The Politically Speaking Hour on St. Louis on the Air is produced by Jason Rosenbaum, Alex Hoyer, Emily Woodbury, Danny Wysentowski, Maya Norfleet, and Elaine Cha. Audio engineering and sound design by Aaron Dorr. The politics editor is Fred Ehrlich.
St. Louis on the Air is a production of St. Louis Public Radio. Understanding starts here.
Do you find yourself regularly listening to episodes of St. Louis on the Air? Suggest us to a friend you think might enjoy our conversations. And leave us a review and rating on Apple Podcasts on the App Store. It's the simplest way to help people discover our show. Thanks.
St. Louis Public Radio is a member-supported service of the University of Missouri St. Louis.